Discover the 2 key considerations for choosing the next step in resistant hypertension management. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-Certified Nephrologist, Certified Hypertension Specialist, Internal Medicine Specialist. See video description for disclosures. During a resistant hypertension multidisciplinary conference, 4 patients are reviewed for treatment failure after maximally tolerated triple therapy with an angiotensin-converting enzyme inhibitor, or angiotensin receptor blocker, a long-acting dihydropyridine calcium channel blocker, and chlorthalidone. Patient A is a 46-year-old woman with type 2 diabetes and obesity. Home measurements in a 24-hour ambulatory study average 166/100 millimeters of mercury, while she takes lisinopril 40 milligrams daily, amlodipine 10 milligrams daily, and chlorthalidone 25 milligrams daily. Serum potassium is 3.8 millimoles per liter. Estimated glomerular filtration rate is 81 milliliters per minute per 1.73 square meters. Urinary metanephrines are normal. Renal artery duplex ultrasonography is normal, and drug assays confirm adherence. She has not yet received spironolactone or eplerenone. Patient B is a 68-year-old man with long-standing diabetes complicated by autonomic neuropathy. Ambulatory blood pressure averages 164/96 millimeters of mercury on losartan 100 milligrams daily, amlodipine 10 milligrams daily, and chlorthalidone 25 milligrams daily. He previously stopped clonidine because of somnolence. Potassium is 4.2 millimoles per liter, and estimated glomerular filtration rate is 77 milliliters per minute per 1.73 square meters. Seated blood pressure is 170/94 millimeters of mercury, but after standing for 2 minutes it falls to 142/82 millimeters of mercury with lightheadedness. Patient C is a 42-year-old man with World Health Organization Group 1 pulmonary arterial hypertension attributed to remote methamphetamine exposure, who is followed for systemic blood pressure control. Home measurements in a 24-hour ambulatory study average 165/102 millimeters of mercury, despite lisinopril 40 milligrams daily, amlodipine 10 milligrams daily, and chlorthalidone 25 milligrams daily. Spironolactone 50 milligrams daily, and later eplerenone 50 milligrams twice daily, were each discontinued after recurrent serum potassium values above 5.5 millimoles per liter. A prior clonidine trial caused severe fatigue. Current estimated glomerular filtration rate is 74 milliliters per minute per 1.73 square meters. Potassium is 4.9 millimoles per liter. Screening for primary aldosteronism and pheochromocytoma is unrevealing, and there are no orthostatic symptoms. Patient D is a 61-year-old man with obesity and obstructive sleep apnea, treated with nocturnal continuous positive airway pressure. Ambulatory blood pressure averages 164/98 millimeters of mercury, while he takes valsartan 320 milligrams daily, amlodipine 10 milligrams daily, chlorthalidone 25 milligrams daily, and doxazosin 8 milligrams nightly. Potassium is 4.4 millimoles per liter. Estimated glomerular filtration rate is 69 milliliters per minute per 1.73 square meters. Renal artery imaging is normal, and adherence is confirmed. According to the 2020 International Society of Hypertension guidance, which patient is the best candidate for doxazosin 4 milligrams orally at bedtime as the next pharmacologic step? Option A, patient D who is already taking doxazosin 8 milligrams nightly. Option B, patient C with recurrent mineralocorticoid receptor antagonist limiting hyperkalemia and no orthostatic symptoms. Option C, patient A, who has not yet received spironolactone or eplerenone. Option D, patient B, who has diabetic autonomic neuropathy and orthostatic hypotension. The correct answer is option B, patient C, with recurrent mineralocorticoid receptor antagonist limiting hyperkalemia and no orthostatic symptoms. The best candidate for doxazosin 4 mg at bedtime is patient C. This question hinges on stepwise resistant hypertension management after failure of an angiotensin-converting enzyme inhibitor, or angiotensin II receptor blocker, a long-acting dihydropyridine calcium channel blocker, and chlorthalidone. The preferred next drug is usually a mineralocorticoid receptor antagonist, but patient C has already had both spironolactone 50 mg daily and eplerenone 50 mg twice daily stopped because of recurrent hyperkalemia above 5.5 millimoles per liter. He also had severe fatigue on clonidine and has no orthostatic symptoms, so an alpha-1 blocker such as doxazosin is a reasonable next pharmacologic option. Patient A is not the best answer because she has never received spironolactone or eplerenone, so standard stepwise care has not yet been exhausted. Patient B is a poor candidate because he has diabetic autonomic neuropathy and documented orthostatic hypotension, making alpha-1 blockade especially risky. Patient D is already taking doxazosin 8 mg nightly, so giving doxazosin 4 mg at bedtime is not a meaningful next step. In summary, the correct answer is the patient with mineralocorticoid receptor antagonist limiting hyperkalemia and no orthostatic symptoms. Primary teaching point: if spironolactone or eplerenone cannot be used, later-line agents such as alpha-1 blockers may become reasonable alternatives. Secondary teaching point: alpha-1 blockers should be avoided or used very cautiously in patients with orthostatic hypotension. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.